Okay, good afternoon, everyone. My name is Ariella Kohanoff, and my team members are
Amy Guzman, Rika Yip, Jeb Wu,
and Celine Park.
And thank you so much for joining us this afternoon for our research project. Uh, that's us. The research question was, what lessons can U.S. cities learn from non-American cities or regions of emergency medical services to improve quality of care? And what policy recommendations could facilitate these improvements? Before we begin our policy recommendations, we want to look at the status quo of LA's current EMS. Today, 85% of all LA calls are medical related, and advanced life-saving support response times sometimes exceed the optimal 8-minute window because of increased call volume and system strain. We also face the wall-time hospital problem, where average handoff between paramedics and hospital staff is 5 hours, leading to less available units. System strain leads to fewer available units and preventable mortality rates. My first 3 pillars of research have been advancing pre-hospital care, implementing fast response motorcycle units, and strengthening coordination between EMS staff and hospitals through data transmission. Pillar 1, advancing pre-hospital, For context, LA's current system is transport dominant, delaying advanced healthcare interventions until hospital arrival. But abroad, we see that advanced pre-hospital care takes place on the scene. And here's a picture from a Paris metro station where life-saving measures are taken well before hospital transfer to ensure that the life is stabilized and preserved. This limits unnecessary hospital transfers and leads to more resources available when transfer is needed. Let's take a look at some powerful international solutions. Japan implemented a mobile ICU unit with on-scene extracorporeal CPR, which led to improved neurological outcomes than transfer-focused approaches to cardiac-related calls. And in the UK, they use an emergency care practitioner model where senior paramedics treat non-critical patients at home. This reduced patient transports by 50%. So advancing pre-hospital care in LA may look like more mobile care units plus advanced practitioners and expanding paramedics' autonomy for high acuity pre-hospital intervention. We could also implement more treat and release practices for stable patients to reduce ER overload and strain of our current EMS resources. The most immediately feasible options could be staffing our current ambulances with more paramedics or emergency care physicians. My second pillar addresses response time by implementing motorcycle response units, which are designed for navigating high-density traffic, and they arrive 2 to 4 minutes faster than standard ambulances to begin life-saving intervention before transports arrive. Across continents, the results are strong. In Slovenia, response times were 2 minutes faster, which is enough time to save a life, as survival rates increased by 5.7%. And in Singapore, response times were cut nearly in half. Even in US pilot cities like Washington, D.C., Miami, and Dallas, response times were cut by 1.5% to 3 minutes. The other benefits of MRUs include the fact that they are flexible to meet the needs of our system. For example, in Budapest, with proper training, ultrasound and invasive central line procedures could be performed by MRUs, highlighting that when we combine fast response with advanced pre-hospital care, we can save more lives. Additionally, the use of MRUs has seen much greater personnel retention than any other EMS unit, which leaves a pool of long-term personnel. This is because people who drive motorcycles also, for their profession, also do that on their days off, leading to less burnout, therefore strengthening our personnel and staff. You might be thinking that this is a gamble with the lives of LA's personnel, but a UK study showed that out of 36,000 MRU calls, only 12 falls were reported, 1 serious injury, and 0 deaths in a 3-year period. Also, this illustrates how we can implement this system safely in LA with proper training and equipment, safety equipment. For LA, actually, LA had a 2012 pilot for MRUs, but they were operated in limited hours and did not use emergency sirens or lighting. In order to optimize MRUs in LA, we need emergency signaling to notify traffic nearby that an emergency is occurring so that they could circumvent congestion. And we would optimize the use of MRUs by staffing them with paramedics or emergency physicians to get advanced care onto the scene quickly. It would be best operated in rush hour and surface level streets rather than highways, and better optimized also in citywide use across multiple districts, not just a few. After considering pillars 1 and 2, the next question is what combination of advanced care equipment, staff, and operations is most feasible for LA's geography? I say that we should implement motorcycle response units staffed with paramedics and increase the number of paramedics in our current scheme of EMS in each ambulance. My third pillar is data transmission, my third pillar is increasing coordination between EMS staff and hospitals through data transmission systems. The problem is that the delayed transfer of patient information leads to a lack of coordination between EMS staff and hospitals, which makes hospitals not prepared for patients when they arrive. This also increases the wall time hospital problem where our ambulance staff are stuck at the hospital with the patient. An example which has solved this problem, or at least mitigated it, is the hospital and emergency ambulance link, which was tested in Singapore. Also known as HEAL. HEAL has reduced the wall time hospital problem by completing patient records in 94 seconds and transmitting them in as little as 4 seconds to the hospital. Data also shows that at least 68% of patient data was transmissible in 75% of HEAL ambulances, as opposed to 25% and less than 5% of non-HEAL ambulances. Additionally, paramedics' time in the emergency department was decreased by nearly half, from 15 to 8 minutes, and waiting time for critical care patients at the ED was decreased from 35 to 17 minutes with HEAL. Also, HEAL effectively prompted paramedics in carrying out treatment in 100% of instances, leading to better quality care before transfer to the hospital. The cost of HEAL, or mobile data terminals like it, is $1,000 to $4,000 per unit. That is one of the lowest costs, small cost will lead to greater resource efficiency in the long term. Across all my 3 pillars, the theme has been shifting capability earlier in the chain of events. By reducing unnecessary transports with advanced care on the field, we reduce the wall time hospital problem and have more available units in our system. Through faster arrival, through the use of MRUs, we get faster intervention and better health outcomes for those in critical cases. And with better coordination using data transmission systems, patients are transferred more efficiently and safely, which also reduces the wall time hospital problem. Thank you.
Hi, my name is Amy Guzman, and I'm going to continue talking about international studies, but my focus will be on Australia and India. And I wanted to highlight key pillars for both of these countries. For Australia, I really wanted to focus on talking about their nationally but regulated EMS system, as well as their emergency worker mental health support services, their elderly care initiatives, and their national health and climate strategy. And then for India, I really wanted to highlight their public-private partnership model, their free 108 toll, as well as their telehealth integrated triage. So why these pillars? When we were presented our research questions, some things we had discussed was emergency responder burnout, as well as rising temperatures, Los Angeles' growing elderly population, and the importance of expanding equity and access to vulnerable populations. So both Australia and India are very large countries with federally regulated countries. India has 28 states, a lot of states, and 1.5 billion population, and Australia has 6 states and a much smaller population, but also has a number of territories. So I wanted to discuss Australia first. Their national regulatory framework allows not just EMS workers to it allows EMS workers to be regulated under one national framework, which allows not just increased transparency and accountability, but also creates national guidelines and standards of practice that really help increase that transparency and accountability across health practitioners. So in Australia, the Australian Health Practitioner Regulatory Agency is what provides the guidelines nationally for health practitioners to train across states. And most EMS services, the EMS system is federally funded. And with the federal funds and federal practices, this also allows professional standards to align, and EMS workers are also able to work across various territories. Unlike where in Los Angeles and across the United States, we see a lot of health practitioners that may need to do different trainings or learn different quality of standards across the states because there is no national regulation. And then the second pillar I wanted to go over for Australia is their emergency worker health support system. So this is heavily nationally funded, and primarily through orgs like Black Dog Institute and Fortum Australia. They receive federal grants, and Fortum Australia actually just received an extension this year for the last 6 months of this year. For 1.75 million, and what they're able to do is serve emergency responders, including police, fire department workers, as well as other EMS workers that operate ambulances or other EMS services. And for example, the Black Dog Institute, what they allow or what they provide is online mental health checkups, and another key item they provide EMS workers is that they allow up to 12 free sessions for these workers to receive these benefits. So not only are these workers getting mental health support from these clinical physicians, but this really allows them to really treat their mental health early on and also treat their PTSD or other psychological harm they have received while they're in the workforce. And then the other pillar I really wanted to highlight for Australia was their elderly care initiatives. For example, they have a national elderly initiative called My Aged Care, which is also supported by their Commonwealth Support Program. And what this allows is, the reason they implemented this is because Australia has such high heat, they really needed something to both provide services to the elderly population and other vulnerable populations that were suffering from heat and other related risks. So what this allows is for providers to not only provide transportation, meals, therapy, and cleaning, but also other tasks at the home. That way elderly can live by themselves and be supported without, and this also is beneficial without, to reduce the elderly having to go to hospitals and just allowing them to stay at home and be healthy. And then the final pillar that I want to talk about for Australia is their National Health and Climate Strategy, which really integrates 7 pillars across public health and climate, and it doesn't only focus on environmental goals. For example, supporting healthy and resilient communities. And across this, they have several policies as well as campaigns and other initiatives to really tackle those 7 pillars. And through this nationally funded plan, what they're able to do is create heat response as well as mental health and a variety of other disaster-related preparedness plans. And what this does is help create a more well-prepared and integrated health system. That way, not just EMS workers, but also people across other organizations that can help in, and offices that can help in disaster responses are prepared and ready to respond to heat and other disasters. And what this does is create more healthy and resilient communities. And then to quickly go on to India, back to India's pillars, their model actually operates on a public-private partnership model. And what this does is the majority of EMS in India is funded by the central and state governments. However, what the private organizations do is they handle dispatch, vehicle staffings, as well as like technology, such as IT platforms. And with this, the most prominent stakeholder is the GVK Emergency Management and Research Institute, which was the one that did start this public-private partnership model initiative back 2 decades ago. And with that, we also have the National Health Mission, which oversees both actions and implementation goals for the public-private partnership model. And with this, I want to go on to pillar number 2, which is the free 108 toll. And this is subsidized by the government. And one thing that I pulled from the National Health Mission's, or the GVK EMRI's website, is how they talk about more than 1 million lives saved over 22,000 emergencies served each day. And with this, they've really expanded the number of ambulances and also the number of care they're able to provide to rural populations. And then the final pillar I want to talk about is telehealth integrated triage. And with this, we have people at call centers, and it is also built into the 108 system, where they're able to provide consultations to people. This is very helpful for people in rural areas because hospitals may be very far from their home, or they might just not have adequate finances to travel, and it also takes up a lot of time to get to the hospital. So this is also really helpful in also decreasing the amount of people that need to go to the hospital because they might just need care that might not be emergency related. So with this, the key takeaways of these pillars are that Australia's pillars have really increased transparency and alignment, reduced burnout across EMS workers, and also created a foundation for treating a patient at the home and expand health initiatives. And then India's has really expanded reach through vulnerable populations through their public-private partnership model, as well as their toll and telehealth integrated triage.
Hi, is this thing on? Hi, my name is Rika, and today what we're going to be talking about for my section is community paramedicine, burden on EMTs and EMS staff, as well as addressing PEH. I'm going to be using the term PEH pretty frequently, and to my understanding, it's an abbreviation for persons experiencing homelessness, which I believe is a rising challenge, especially within LA City. So let's talk a bit about LA's current EMS landscape. They're experiencing a very high call volume, as mentioned earlier, particularly from PEHs. Even in all of the United States, LA City currently has the third highest volume, where 13.8% of the calls are from PEHs, which is 339,000 people. And that consists of 0.8% of residents, in 10.2% of incidents, and 13% of transports. And there also is a case of repeated transports. Oftentimes, firefighters or paramedics will see the same person 20 to 30 times, according to the California Firefighters Association. So what has LA done so far to respond to this? They've developed FR9s, which are fast response units, and APRUs, advanced practitioner response units. These two allow for LA City to respond more quickly to these types of incidences, as well as have more specialists on the team. Additionally, what they've also done is implement therapeutic vans, which is done in collaboration with the Department of Public Health. Therapeutic vans are typically staffed by both a psychological technician as well as a peer support staff. Why is this an issue? Well, therapeutic vans have actually been recommended recently to be terminated. In a lot of cases, it requires a dual-sided approach, both medical and psychological, when it comes to dealing with PHs who experience, on average, more mental health and substance abuse issues. Additionally, our current EMTs and firefighters are not currently equipped to deal with complex mental health and substance abuse issues. It's not part of any training that's currently part of them, and a lot of people in CFA have expressed distress or even despair in some cases when it comes to being able to adequately treat their patients. Finally, there's an inadequate amount of APRUs despite constant requests since 2023. This leads to EMS burnout and exhaustion, and this is not helped by the current resources we have. LA has done a great job by launching their behavioral health program, which includes campaigns like breaking the stigma surrounding mental health and providing department psychologists for stations. However, in the entire staff of 3,500 people, according to a 2024 estimate, there are only 2 departmental psychologists, and each can only take on a maximum caseload of 16, which is inadequate for what is needed currently. Additionally, the United Firefighters of Los Angeles City offer a peer support system, which is shown to be an effective other way of dealing with mental health crises. However, imagine you are dealing with an incident or you have a particularly distressing day at work. If this is the page that you have to go to in order to navigate peer-to-peer support, how can we break this? How can anyone truly receive the help they need? So I decided to look actually more locally at New York. The 3 reasons why I decided to look at New York was, first, their data provision. They offer a very high call volume and response time data very similar to LA. Secondly, they have a very similar metropolitan sprawl to LA and have a high PEH call volume for their EMS teams. Thirdly, they've done a lot of innovative pilot programs and integrated public health approaches, which I think LA can take on in order to improve the current call volume situation. While California focuses mainly on diversion, New York focuses on on-site treatment. So let's talk about some of these programs. The first one is Be Heard. And what Be Heard does is they respond to frequent emergency dispatch utilizers, like in LA's case where they have people coming 20 to 30 times. What they do is they have it paired with their mental health and public health department, and it allows for EMTs and call responders to directly refer them to sobering centers or to psychiatric treatment. Additionally, there's also ECHO, which stands for Extension for Community Healthcare Training. ECHO is basically a peer support program that meets online, so it reduces, 1, the cost of having psychologists in person, and 2, it allows for people to connect with people even beyond their station, discuss their issues, and be able to have a data-driven approach. Okay, sorry, apologies. Next, we're gonna look a little more locally at California and this concept of community paramedicine. Community paramedicine is defined as a new model of care-enabling paramedics rooted and closely connected with their communities to provide expanded services beyond their traditional roles of emergency responses, according to the UCLA Center of Public Health. So here are 2 of the greatest examples that I could find within California of systems that practice community paramedicine. The first one is in San Francisco. EMS 6. What EMS 6 does is it focuses on redirection. It supports beyond the traditional delivering patients to the hospital by having specialists in overdose and behavior. They receive referrals from responders and EMTs, which allows them to build trust-based relationships and have people achieve the social services they need. Secondly, we have Hayward, which I think is the most interesting of them all. When you call their 911 line, they put you to a link team, and the link team can either direct you to HMET, which is the active mental health crisis, or MIHU, which is the mental health integrated unit. The Mobile Integrated Health Unit. And this allows for responders to make a decision and for people to access the resources they need more urgently if they call with a mental health emergency. The MIHU is also very experienced with dealing with people with PEH, which is something that I think LA definitely needs. They also do, like I mentioned previously for all the other programs, a combination of psychological specialists as well as EMTs. So you have both the medical and psychological help. So this is my first recommendation. These are some of the steps that you can take towards building a community paramedicine program. Because California, there's a lot of history of workshops or exchanging information. You could obtain information and data from Hayward and SF and see how they are implementing their programs. Additionally, you could build something called a CCRT, or a community-centered response team, which involves both those psychological specialists and EMTs. Finally, I think a data team would be best to support this. A data team would allow for things like pre-surveillance or knowing where hotspots of frequent callers are. As well, and you're wondering, how could this fiscally be supported? Well, in previous examples, like I mentioned with the therapeutic vans, a collaboration with departments like public health or mental health services could help redirect resources more easily and relieve any fiscal concerns. Finally, my second recommendation is to improve the amount of peer-to-peer programs. So mental health programs, as I mentioned earlier, obviously hiring more clinical psychologists is very expensive, but peer-to-peer support is a good way for people to communicate with one another and foster a better community within the EMS teams. So we could adopt more of New York City's models by having EMT-oriented therapists, implement ECHO peer support training, and look to partnering with potentially well-trained grad students to substitute as psychologists for the department.
Alrighty, so my previous peers have mostly talked about other areas along with specifically rising heat and community support programs. And I would kind of like to echo these points by focusing on what exactly we're expecting in Los Angeles in the coming decade. That's specifically what I looked at, so I basically just ran through a bunch of data. And what we're covering today is current health profiles in Los Angeles, which is specifically what are the people of Los Angeles struggling for that lands them in emergency departments and to call EMS systems. Additionally, as Amy was talking about earlier, Los Angeles temperatures are rising, as well as, so we need to find out where exactly they're gonna rise the most, as well as in the future, dealing with infectious and parasitic diseases. I'll go into specifically why infectious and parasitic diseases in a later slide, but for now, let's focus on, oh man, that is weird. Current health trend data. So this data is taken from Los Angeles emergency departments and emergency departments statistics taken from the Los Angeles Department of Health. And as you can see here, this is the proportion of emergency medical services diagnoses. So this is specifically what people are going into EMS and going into emergency departments for. As you can see here, a lot of the proportions between 2020 and 2024 haven't changed drastically. Some of them have even dropped in some cases. But what you don't see from this graph right now is that for each in 2024, call volumes have risen from 2020 by up to 3,000 calls in each of these cases. So while the proportion of it hasn't changed so that we can focus our resources on a specific condition or area, what we know is that call volume is rising. But why is that the case? The first potential issue is with rising heat. Heat exhaustion death rates have risen from 2000s to 2020. And in fact, in July, temperatures have risen from the average heat to 7 degrees higher than average in 2024. Heat increases, raises blood pressure, metabolism. Overall metabolic rate goes up, and the body's working harder in order to try and fight off diseases. And as a result, it exacerbates pre-existing conditions in vulnerable communities, as well as causing heat exhaustion in our unhoused populations, leading to greater call volume. So, where is heat the highest and who is the most vulnerable so that we can focus our resources on these specific areas. For this, I looked at temperature maps. This specific map are where urban heat hotspots take place. So this is specifically for very hot for the summer months, such as July, June, August, where heat is at its highest. So as you can see here, key locations are in San Pedro, Harbor City, Wilmington neighborhoods. These darker spots are where urban heat hotspots are the highest. In addition, this is a heat severity map. This specifically focuses on the average temperature from across the year. So we're looking at higher temperatures, not just focused on the hotter summer months. The key locations here are Chatsworth, Panorama, Van Nuys over here, as well as Lincoln Heights and Chinatown on this side. Now, I understand that you guys are focused more on LA City as opposed to LA County, but I believe that this information could provide some good ideas in case the people over there need additional resources from us. So, where are the vulnerable people located? Particularly, individuals age 60 and above are at the greatest risk of dealing with these, not only dealing with pre-existing conditions, as well as dealing with heat exhaustion. So I specifically looked at individuals age 60 and 70, and it turns out, this is data taken from the US Census, that Chatsworth and Porter Ranch up here also not only have high individuals age 60 plus, but also happen to have very high heat severity. In addition, individuals age 70 currently are stationed at Century City. So we can expect that not only just due to heat, but due to their pre-existing conditions, that will have higher call volumes in these specific areas. Additionally, another vulnerable population happens to be children, especially since oftentimes they are outside, they have to walk to class, all that kind of good stuff. And these children happen to have a very high population in Southeast Los Angeles, Central City, Watts, and Wilmington. And these are also the areas that have incredibly high urban heat spots, up to 8.5 degrees above average. So, what are some potential solutions? One potential solution, as my peers have been advocating for, are increasing the number of nurse practitioner units and advanced provider response units. The quickest way in order to get over heat exhaustion is to insert an IV into one of the major veins and cool the blood. However, you need to be a nurse practitioner in order to be licensed to insert an IV. In addition, another way is to highlight through prevention campaign trainings, which Celine will go on to later, to direct callers or those who are suffering from heat stressors into cooling centers that already exist in LA County. In addition, through public health campaigns, we can point to people who are enduring heat stressors to go to these locations instead of calling EMS. An additional way to solve it is through syndromic surveillance, which I will go into later, but essentially what it is EMS services, public health, emergency departments will essentially be monitoring the conditions that people are going through and be able to send out information to communities so that they're able to prevent it. Alrighty, potential issue 2, infectious and parasitic diseases, which I will be referring to as IPD. Who here has heard of COVID? Raise your hands. Yep. Who here has heard of Ebola? These specific diseases are going up significantly. If you thought that maybe there's a lot more infectious diseases that I'm hearing about that are tearing through communities, that is only going to go up in the next decade due to rising heat, due to the fact that due to microbial adaptation and change, ecological changes, travel, we cannot expect to deal with public health trends in our current system, as well as the fact that just due to globalization, even if there's a disease in another country, it could very easily come to a very large population, high density population such as Los Angeles. As a result, here are some potential solutions. Once again, nurse practitioners are often the best way in order to deal with infectious and parasitic diseases. However, nurse practitioners must obtain a Drug Enforcement Administration and complete specialized information training in prescribing these medications. Or they can be overseen by a physician. However, each physician can only take on 2 nurse practitioners under their wing. I suggest nurse practitioners specifically because oftentimes antibiotics are the quickest way in order to get these prescribed and get people the help that they need. An additional solution you might think, is to establish infectious and parasitic disease research centers. The only issue with this currently is that setting up a new infectious and parasitic disease research center is really difficult. Chemical sequencing lab material can cost up to $500K, and that's just for one specific research lab. And it's also very difficult to use universities for disease research because typically universities such as UCLA and USC are already focused on one specific disease and trying to find the treatment for that, as opposed to being initiated to finding new sequences. Oftentimes, the best solution is to collaborate with community health workers, unity partnerships, and especially privatized healthcare systems, or privatized healthcare organizations such as Pfizer and Moderna, who already have not only the researchers who are already prepared to sequence new diseases, but as well as the financial backing in order to support it. Another potential solution for IPD and for heat stressors is syndromic surveillance. I already went into this, but essentially what this looks like is that patients seek care at emergency departments or in EMS systems. Those EMS systems then contact local health departments as well as health information exchanges through the more centralized health informatics that my peers have described. And then those systems will then contact the public and issue statements in order to prepare the people through text message warnings, public health campaigns. And this lowers operating costs and wait times by allowing people to the opportunity to go through preventative care by themselves as opposed to relying on our current systems. So our key takeaways here are rising temperatures and infectious and parasitic diseases. To counter rising temperatures, we can lean on cooling centers, as well as resources as well as pooling resources in Chatsworth, Porter Ranch, all these locations. And for infectious and parasitic diseases, we can collaborate with other health services, organizations, and industries in order to subsidize our funds and help leverage a future COVID pandemic from happening. For both of them, once again, more nurse practitioners and syndromic surveillance and public health campaigns can help educate the community and prepare our systems to counter these struggles later on.
Thank you. Hi, my name is Celine, and my portion of the presentation will focus on what lessons we can learn from international EMS systems and how these inform a public health campaign strategy. We'll see from across Europe that these reformations to their health systems will not really work without the public properly understanding how their systems work. So why do we look at an international model? We're looking today at Portugal, the UK, and the Netherlands because all these countries have faced similar EMS pressures like long wait times, high volume calls from low acuity patients, and long wait times. And these solutions really combine a system reform plus a public education campaign in order to properly communicate to their citizens on how to utilize these resources that are available to them already. So from all these case studies, we see that behavior change is truly possible at scale through messaging that is simple, accessible, and clear. First is Portugal. The Portugal National Health Services has seen rising call volumes from low acuity patients, especially in winter peaks. And in response to this, they created a national health campaign called Ligue Antes, Salve Vidas, which means call before you leave, save lives. They did this in order to utilize their SNS 24 phone triage line, which encouraged patients to call first their SNS 24 and be able to assess the proper acuity of their medical condition and be directed to the appropriate services at hand in non-life-threatening conditions. They utilized this SNS 24 phone triage line with a nationwide push of a public health campaign, partnering with journalists and TV programs, artists, in order to properly share the message with their citizens. And Goiânia da Silva conducted a survey on the actual impact of this public health campaign and found that when these pilot programs were pushed out into the community, emergency department use for low acuity patients had decreased while SNS 24 phone line use had increased overall. So the key takeaway here is that public campaigns really work, but it also must match capacity for their personnel. Portugal is now seeing an increase of phone calls, while their personnel is lacking in the capacity to handle the call volume. Next is the UK. Likewise, during winter peaks, the UK sees an overwhelming amount of emergency department calls. Their emergency department, called Accident and Emergency, or ANE, sees up to 2/5 of patients that could have been properly cared in an alternative care department. In order to combat this, they created the NHS 111, which is, again, a platform that is able to direct patients into the proper care that they need. Through simple messaging, such as "get to the help you need," they allow the citizens to understand that by helping themselves, they also help the healthcare system as a whole. They utilize online tools like their website, their social media, and YouTube channels in order to communicate to the public on how to use NHS 111 and what are their alternative care destinations, like their urgent treatment centers, or for us, their urgent care. And they also properly utilize their YouTube channels in order to communicate the same information on how to access these services and what is appropriate in what types of situations. So the key takeaway here is that simple messaging that is clearly accessible to all ages and demographics and an easily navigable system combined can allow citizens to use the resources that are already available to them. Lastly is the Netherlands. The Netherlands has a primary care-led model, which means that their general practitioner is their first point of contact in any medical condition. So this clear messaging and understanding of citizens allows whoever is in a medical emergency or non-emergency to first contact their general practitioner. However, in the early 2000s, they saw that emergency department use was rising, and hence they created the GP cooperatives, which is a general practitioner service that is available after hours, so after the regular 9-to-5s. And these physicians and general practitioners are able to then gatekeep who is able to attend the emergency department in non-life-threatening conditions. And again, public dissemination of this information makes it so that it's a clear behavioral change and an innate understanding that their general practitioner is their first point of contact. So as we can see, clinical reforms only work when the public knows how to use the system. Why a public health campaign? A mass study by Wakefield et al. Found that public health campaigns can be tremendously impactful to changing health behaviors. When messages are repeated so that it is integrated into people's lives and social circles, when campaigns are specific and simple so that people aren't getting bombarded with vague information or jargon that they don't understand. And lastly, that services are accessible so that true health behavior change is realistic. So we propose a simple campaign goal: to reduce low acuity cases by teaching the public when to call 911 and use EMS, when to use urgent care, and how to access these other same-day options like sober care centers or services specifically for people experiencing homelessness. Our first campaign pillar is to redesign the LAFD's website. First, when you go to the LAFD's website and find the EMS Bureau's page, it is simply a paragraph upon paragraph on what the EMS Bureau does. We instead propose to change this and redirect and put it in the forefront. What are the resources available to you when you need EMS? So call 911 immediately if you're experiencing the symptoms. If you're not and you still need help, what are the urgent care services near you? What are the alternatives that you can go to? And what are the other specialized units that are in your availability? And then talking more about the EMS as a whole. Next is a social media strategy. LAFD has 255,000 Instagram followers. However, most, if not almost all of its content is fire related, even when LAFD's 85% of the LAFD's emergency response is EMS related. So we propose to leverage this wide net influence in order to use hashtag #MakeTheRightCall infographics in order to educate the public on what resources are available, scenario-based reels to make it salient for people on what to do in certain situations, Mythbusters 911 edition, interactive story quizzes on is this an emergency, and partnerships with EMS content creators so that these messages are accessible to all demographics. Next is a YouTube mini-series. What the NHS 111 does really well is creating videos and advertisements that make these messages more emotionally and more emotionally captivating. So first, when you go to the NHS 111's YouTube channel, the first video you get recommended is their ad for Get to the Help You Need. In comparison, again, the LAFD's YouTube channel highlights an insight into their training. So let's watch what they do in order to make these messages more clear and highlight that when LAFD and their EMS systems is able to properly work is only if and when the people are able to use them effectively.
This is bad. Something's not right. This could be an emergency.
Stop panicking. Okay? We're going to bring that in. We don't want to waste anybody's time.
Hang on. According to this forum, it could be indigestion. Or exploding appendix. I really don't know what to do. Okay, go.
Just chill out, man.
When you're not sure what to do, go straight to 111, and if needed, a healthcare professional will call you. Help us help you know what to do.
So our theory of change is simple. When you partner campaign activities with proper reforms, this can create widespread behavior change so that the public knows how to use the EMS systems correctly. And then it helps the system as a whole. We have patients that know what care centers they should go to, and it also helps reduce low acuity EMS calls, ED overcrowding, and again, just helps the system as a whole.
Just to recap our final recommendations, mine were expanding the use of advanced care practitioners by staffing some on faster motorcycle response units and implementing real-time data transmission between EMS vehicles and hospitals. And also, those are my recommendations.
And to expand on that, also expand collaboration with elderly care and climate health offices or organizations.
To do a greater investment in nurse practitioners, as well as develop community paramedicine teams via cross-agency collaboration and expanding peer-to-peer supports.
And finally, again, using a public health campaign so that the people know that all these other services and the services that are already available to them and how to use those. Thank you so much.